Welcome to our conversation on treating IBD, what's next for me. We're apologizing in advance as we tried to go live on Facebook. Unfortunately, had some technical difficulties. So we are continuing the conversation and happy to record it and have it out to you as soon as possible. As we know, Crohn's disease and ulcerative colitis are chronic conditions that are unpredictable, like tonight, and can change over time. Currently, there is no cure for IBD, but there are a number of treatments that are available to our patients. We're going to discuss now how and why treatment plans may need to be adjusted throughout the IBD journey and how patients can help navigate these changes. My name is Alyssa Strauss. I'm the Senior Manager for Adult Education and Resources at the Crohn's and Colitis Foundation, and I have the honor of moderating our program. We have with us Dr. Tina Zhang, a pediatric gastroenterologist at Indiana University, Riley Hospital for Children at IU Health. And we also have with us Dr. Rajesh Shah, an adult gastroenterologist in the Baylor Scott White Health System in Austin, Texas. Both Dr. Zhang and Dr. Shah are members of our foundation's National Scientific Advisory Committee. Thank you both for joining us. I just want to go over a few quick pieces of housekeeping. The information that we provide for you right now is meant for educational purposes only and should not replace any advice you receive from your gastroenterologist, your primary care provider, nutritionist, or surgeon. If you have additional questions about your specific care, please reach out to your healthcare team. If you have questions about IBD that are not covered during this conversation, you can contact our IBD Help Center, and they can be reached at 1-888-MY-GUT-PAIN, or you can email at info@crohnscolitisfoundation.org. This program is generously supported in part by a sponsorship from Takeda, and additional support is provided through the Foundation's annual giving program and our donors. So let's get started. Dr. Shah, let's talk about when a patient is first diagnosed with IBD. Are medications necessary to help control that inflammation?
Sure. So the short answer is yeah, we're going to probably recommend medications to help control that inflammation. That said, I'll usually go through with the patient about the diagnosis, what the inflammation we think is being caused by, and kind of the importance of being on medications and particularly long-term need for medications. Also, I'll kind of frame this in a goals of care discussion, kind of what are we trying to do with these medications in terms of controlling inflammation, and then again, stress the long-term need for them.
So what are some common ways that you treat IBD? What do you perhaps commonly prescribe for your patients?
Sure. So when I discuss treatment with patients, I kind of put it in the context of why am I choosing different medications? So one of those might be just how severe is their disease, and the other would be what potential risk factors they have for more complications down the road, whether it's ulcerative colitis or Crohn's disease. And kind of with that in mind, then I'll describe the different therapies we have available. Thankfully, we have quite a few now. We'll talk about some of the older medications like mesalamine or azathioprine. Might also talk about steroid medications like prednisone and budesonide, some of the many different biologics we now have available, as well as small molecule therapies, and try to go through each one of these and decide on what might be the best fit for that patient.
Dr. Zhang, as a provider of pediatric patients, are there perhaps specific treatments that are generally used for pediatric IBD patients?
That's a great question. And the short answer is yes, there are certain therapies that I think we in pediatrics tend to use more so than adults, but I think also just even before going into those, I think also it's important to highlight that a lot of the medications that are available, we're lucky in that pediatric patients often respond to those as well. And we can talk about more later some of those newer biologics and small molecule therapies, unfortunately, aren't always as readily available, but in a lot of the ways that the disease process and inflammation is driven, we can use those same therapies. But For things that are specific to pediatrics, I would highlight specifically nutritional therapy or exclusive enteral nutrition, as well as antibiotics, and then get the importance of genetic testing for some of our patients. And so for nutritional therapy, I think there's so much interest in IBD and trying to understand what drives it and what contributes to that inflammation. And it's really incredible seeing some of the pediatric studies that show how quickly our patients can respond to changes in the diet, not just with formula, with exclusive enteral nutrition, but seeing groups like from Dr. Levine's group in Israel with the Crohn's disease exclusion diet, and now even more data coming out in terms of how do we make formula therapy more accessible. So thinking about combining that with a Crohn's disease exclusion diet, partial enteral nutrition, and just trying to get a better understanding of what we can control that might contribute to controlling that inflammation through diet. The second part of that, that we have really interesting data in pediatrics, is the response to combination antibiotics as well. And these are not long-term solutions, and I definitely agree with Dr. Shah in terms of thinking about the long-term goal, but sometimes using things like diet and multiple antibiotics can be really helpful in controlling that acute inflammation. And then just going back to genetics, I think we all understand that genes are a big part of what drives Crohn's disease and ulcerative colitis. But when we get down to younger and younger patients, when they first present or are first diagnosed with IBD, then we have this higher percentage of patients that might have what we call monogenic disease, where there might be a single gene, genetic change or mutation that is responsible for that inflammation. And that's really important to know for us, because some of those can actually be treated with a very different type of therapy, even stem cell therapy. And so getting that information can be very helpful for our younger patients.
Dr. Shah mentioned a few things, how do you decide, what medication might be right for a patient? And you mentioned, the disease and the location. What would you say for pediatrics? How do you decide which medication might be right for one of your patients?
I would definitely agree with all the things that Dr. Shah had said. I think the most important thing is understanding how severe that disease is. So if we think about what might be mild or moderate or severe, and kind of with that, are there complications that have come from that disease? And so thinking about things like fistulizing disease or stricturing disease or scarring that comes with more severe disease, that can definitely guide therapy in a specific direction. If with some of those complications, things like infections, that might affect that early decision as well. I think for pediatrics, what a big thing when we think about the severity of disease is growth delay and onset of puberty. Those are things that should be happening in all of our pediatric patients, but having inflammation can really offset the timeline and the cycle. And so if that is affected, then that really tells us how much inflammation is going on, and what type of therapy might be better, and how quickly we need to act.
Okay, thank you. Dr. Shah, so let's say you decide on a treatment and the patient starts their medication. How do you determine if it's working, and what are the signs or indicators for when it may not be working?
Sure, yeah. So probably the most readily available thing would be symptoms. So asking the patients frequency of bowel movements, presence of rectal bleeding, their abdominal pain, different things like that. Those would be kind of obviously the most easily available kind of symptoms to us. We could certainly use blood tests. That's another potential option for some patients. We may check something called a C-reactive protein. That's an easy blood test we can do to kind of track inflammation, but unfortunately for some patients, they just don't produce that, so we can't use it. Another kind of maybe called non-invasive test would be stool testing. For the right patient, we can certainly use that, and it can be highly accurate in patients and very sensitive to changes in inflammation. So that might be another test we can use over time to see, okay, has our therapies worked? Is this patient more or less in remission and their inflammation is very well controlled? Depending on the patient and where their disease is, particularly say someone with Crohn's disease involving the small intestine, we may use different kind of imaging tests. So a CT scan or an MRI, something called an enterography test. A great test to be able to track inflammation in other areas that we maybe can't easily reach with colonoscopy. Similar to that, we might use something called a video capsule endoscopy. In the right patient, we can use that, and basically the patient swallows a pill that's a camera, goes through their intestines, and we can get very good looks at the small intestine, see has inflammation improved. And then obviously we have endoscopy, particularly colonoscopy, where we can directly look, take biopsies, and kind of reassess how our therapies worked.
Thank you. And Dr. Zhang, similarly for pediatric patients, are there certain indicators that are specific for our younger patients to know if the medication is working or not working?
So definitely, I think number one is just assessing, is there a change in symptoms? Some of our younger kids can be a little bit harder to tease that out and get how they're doing, but the parents are really helpful in terms of seeing, is there a change in how their child is doing? And all of the tools and modalities that Dr. Shah had mentioned, we use as well. Some of them can be a little bit more difficult in terms of, can we sit through a full MRI scan? I think that's challenging for anyone. And then a big thing that we like to look for more on the long term is that recovery of growth. So not just are they recovering weight loss that maybe they initially presented with, but are we also seeing over time that recovery in height as well? And so those are really two important signs for us.
Thank you. And so let's say the medication is not working, Dr. Zhang. What are next steps and options for those patients? And how do you help those patients when they're trying to make that decision to switch? And what do they do sort of in between when they made that decision to switch? Is there something that you can give them to help with the symptoms that you're talking about?
Right. I think if we're dealing with symptoms or abnormal lab tests or concerns that the therapies aren't working, I think it's helpful to take a step back and kind of make sure we understand that what we're dealing with, because unfortunately there is often overlap, making sure that there's not an infection like Clostridium difficile or C. difficile infection. Sometimes patients are doing well in terms of inflammation, but we have things like irritable bowel syndrome that unfortunately can overlap with IBD and other things like that. But if we're at the point that thinking that the inflammation isn't well controlled, then sometimes there are options to what I like to call kind of bridge therapy to get us to that next step. And it's really just kind of using the medications and therapies that we know can work to help get things quickly under control and then transition to what's going to be that long-term maintenance therapy. So again, in pediatrics, we love things like nutritional therapy, if that works for some, but things like steroids, combination antibiotics, certain medications that act more quickly are ways to help us at least get on the right path.
Thank you. Dr. Shah, so I want to ask you a little bit about clinical trials. Patients may have questions. They hear, if a medication is not working, maybe I should try a trial. Can you talk a little bit for us about what trials are for patients and caregivers who are not familiar with them, and maybe share with us when it might be a good option to consider a trial?
Sure, yeah. So clinical trials are basically research studies testing some either new agent or new procedure or something new to see, okay, is this going to have an effect? And once it's gone through the clinical trials process, then it can get FDA approval and be used kind of more widely. And for better or for worse, I think people are much more familiar with clinical trials now after closely following them during the pandemic and seeing things getting through the approval process. There are many stages to these. There can be early stage clinical trials and then kind of later stage clinical trials, which people may be a little bit more familiar with. And as far as, is it the right fit for a patient? It's really a discussion with their doctor. Of the different therapies we have available, is anything working. If it's not working, okay, well, maybe clinical trial is the right option, or for the right patient, maybe they just want to try a kind of drug that's in testing that's got no kind of analog that's already been proved. And maybe then we use that. And sometimes patients can even go kind of research this through different websites such as clinicaltrials.gov. That's a kind of repository for all of these. So that's kind of where people might want to go. And obviously, again, talk with your doctor.
Dr. Zhang, we know that trials typically generally start with adult patients. So can you tell us in what cases you typically refer pediatric patients to clinical trials?
That's a great question. And I think clinical trials are such a huge opportunity for our pediatric patients because it gives them access to medications, therapies, other interventions that we wouldn't normally have access to. And I think just kind of starting off, as Dr. Shah mentioned, there have been so many recent developments in therapies for IBD. When we think about biologics, there are a lot more than a handful, but unfortunately, only 2 of those are approved for pediatric use. So everything else, if we were to need that, would be off-label, and that comes with a whole host of not just red tape, but it comes with a lot more that has to go into that. And so I think if there's a patient who is not responding to the therapy plan that we initially came up with, then getting into a clinical trial can get them access to some of these medications that we know are effective in adults. But we just don't have that data yet in pediatrics. And unfortunately, when we think about clinical trials as a whole, pediatrics is a small slice of that pie, but obviously for us, it's a very important slice. And so it's such a valuable opportunity. I think, of course, there's always the unknown with novel therapies. And so that involves a really good discussion with family, parents, and their provider. But I think it's an important part of pediatric care just because we know, unfortunately, not all of our therapies will work off the bat for everyone. And so it gives us access to a lot more opportunities.
I want to sort of cap up this conversation talking a little bit about communication. So Dr. Shah, what are some things that patients can do to communicate with their doctors when they do have concerns about their current treatments?
Yeah, so this is important. So first off, again, I like to start with just really trying to educate patients on why we're selecting certain treatments, direct them to good resources for these different treatments, because again, they're long-term treatments. So it really requires buy-in from the patient and understanding that, we're going to start this and we're going to be on it for quite a while. This isn't something we do for a month or 2 and that's that. So really stressing that at the beginning of, okay, here are the different treatments, providing different educational resources, and then really trying to press that if something's not going the way they expect it to, say we're starting a new treatment and they continue to have symptoms, or they've been on a treatment but they start having new symptoms where they weren't before, to reach out early. Unfortunately, I run into still a lot of times where patients start developing symptoms and they have an appointment already scheduled in a couple of weeks or even a month or so, and they just kind of keep going with that. And then when they get to their appointment, they tell me, hey, I haven't been feeling that great. And then they've just kind of been suffering needlessly. We can do a lot of things in between there to kind of start sorting out what's going on. Are there infections? Is there some adjustment needed in medications, whatever it might be? So just stressing when something changes and you're kind of not feeling right, just let me know, get in touch with the clinic, get in touch with your doctor, let somebody know.
Thank you. Dr. Zhang, what about for you? Any tips for parents about monitoring symptoms or communicating concerns about their child with their doctor?
Would absolutely agree with Dr. Shah that starting early if there's anything that is off, and I think parents know their child best and they recognize those changes probably well before maybe even they do. And so I think if there's ever any concern, to reach out to their team, to the GI clinic, their doctor, their nurses, and just letting them know what's going on. that communication is so key. And we think of it as a group, that there's the patient, the child, the family, all the other caregivers around. And I think it's such an interesting dynamic is how that changes as that child grows older and then eventually transitions to this independent adult that will then go on to manage their own healthcare effectively when they transition to an adult GI provider. And that's always our goal. And so we try and get them used to that idea early on of recognizing what symptoms are important, what they should call their doctor about, call their parent, even if they're off at college or at camp or something, to recognize those signs early on and take an active role in that.
Thank you. Well, thank you both for joining us today. Appreciate having you both here to share your expertise. If there are things that we didn't cover in this program, we encourage you to visit our foundation's website, which is Crohn's Colitis Foundation.org. You can contact our IBD Help Center by calling 1-888-MY-GUT-PAIN or emailing info@crohnscolitisfoundation.org. We hope this will be recorded, and we hope you'll be able to share this recording with anyone you know who is battling IBD or a loved one of someone with IBD. We want to continue to serve our community with programs like this, other critical education and support programs that our patients need now more than ever. So thank you, Dr. Zhang, Dr. Shah. Thank you to our sponsor, Takeda, and our donors for their support. And thank you again. Take care.
Thank you.
Thank you.